Hopefully he's inside.
Attempting to talk to his wife. Again, Berlin backup, your call is to 175 Arnold Street for a 75-year-old male who's selling his head. If I hear
So managers roundtable quick, Damien and I will get it out, I don't know who's going, but new scheduling software coming out first of the month, or first of the year. So just watch your emails for that, for login and any information, if anything gets pushed backwards or comes up faster or any of that, so.
Same company?
Sound window work?
LDEC is where we're going with.
Really?
Yeah.
I got a lot of information on them when I had gone to a conference. They are fabulous.
That's where we're going with.
ALADEC.
Yep.
They're amazing.
So, other than that, managers can go around and then training Jason's gonna provide on sepsis and we're gonna go from there.
Primary's gonna take it.
Primary just said they're taking it.
Oh, well, there you go.
Somebody forgot some radio.
No, Green Lake Primary is gonna take it.
Oh,
That's
Green
what
Lake
she said.
Primary is what they're doing.
Yeah, they're asking.
So they're asking for Green Lake Primary.
Hey, we're not anywhere.
So who you going with? Josh. Oh, I'm on
Oh, yeah,
primary
Josh.
right now.
Sure, if you want to.
Okay, there you go. Don't eat my time.
Oh, I'll think about it.
There's a few more up there just in case she does, don't worry.
So now that we got rid of Josh,
Who else can we
Quite
get
out
rid
the
of?
door yet.
another set of pages,
They love the pages.
but this is gonna be on
Oh,
all.
this is Green Lake.
I don't know, but
Primary calls to
I cannot stand that. I don't hear it. So mine has to go beep, 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 otherwise I'm totally not able to speak.
Unsure if he's bleeding at this time. He is talking, but not making a lot of sense. Again, Green Lake Primary calls to 175 Arnold Street in the city of Berlin. For 75-year-old male, he's selling his head. He's 673 clear at 656.
Was she married to John?
So, we're gonna start the managers roundtable quick. Evan's not here tonight, he is not feeling the best, he didn't wanna get anybody else sick, so he's at home. Bethany's on a transfer, so we're missing those two. Next month, we will do the yearly recap, so number of calls and, the volunteer working most hours and things like that. Evan had all those numbers, and since he's not here, we didn't get those. I don't have anything. Reports have been getting it on time at Project Fix, so I'm good there. I will go counterclockwise.
Signing reports again. Also, every time you take a patient to the ER, transfer, always get an RN signature for transfer of patient care, either electronically or at the bottom of our run sheet. There is a line for that as well. I think that's all I got.
Adam's next. Right? Yeah.
Door code changed in Princeton,
And it's gonna change again.
and it's gonna change again. So once,
You know there's only 5 numbers on the door, right?
You know that you can push 2 buttons at once and make it one number?
I did not know that.
I might do that, just to mess with people.
I just tattooed the last one you gave me on me so I wouldn't
I
forget.
went over there to get reports and I was like, okay, boop, boop, boop. Oh, that's right. Adam emailed me. Then I looked at your first email. I'm like, dude. Are you kidding me? Went
Yeah.
back through. I was like, oh, he emailed me a 3rd time.
Why is it changing again, if I
the,
may ask?
the door is
The only
broke.
reason that there's a 2-digit one on there is because I couldn't get 3 digits programmed into it. So I have a new one coming and then I will change it to whatever one the people in charge approve.
5, 4, 3, 2, 1.
5, 4, and 3 at the same time, 2, 1.
Yes, please.
You want it to be,
Stick your hand on it, just.
If Wayne comes back and runs for us, he'll be able to open the door. So,
What's the door
Sorry.
code now?
5-3.
And then to change it next week?
It'll, I just got it in yesterday, so I have to get it put in and get it programmed to whatever the people in charge have to say.
Can you send out a when to work message with, so everybody gets it? Or if you send it to me, I can send it out to you.
I will
way
do that.
everybody has it.
Someone will. These 2.
Within 48 hours, you guys will have it.
40,
He did not say a 48 hours of what day. Don't let him pull that shit on you. I know what he's thinking. No. That means like from Saturday. A week from Saturday, 48
You'll be
hours.
notified.
Or 48 hours from January 3rd.
That's it?
That's all I'm aware of.
If I send it straight to Med One, it would be fine.
The email or the phone?
I'll just text you.
Yeah, that person that has the phone might go like, what? Why is he just sending 3 numbers?
But that's what I'll do. I'll send a message to Adam and Ernie, and then I'll send a message to Med One.
That works. Heather?
Josh was just talking about the new scheduling system that we were gonna put into place. Evan's got all the details on as far as like the actual setup of it. Like Josh said, we're hopefully gonna be able to get it up by the 1st. I guess Evan's still working out some details of that. We might be having our next training in the computer lab at Berlin, because we wanted you guys to be able to like log into a computer and actually use the system so we can show you guys how it works and show, then everybody can be able to play with it and actually figure it out. I have the computer lab at the hospital reserved for us, but it all depends on if Evan can get the system up and running, and then it depends on the IT tech that I was talking to doesn't seem to realize that we're not Theta Care employees, so I don't know, he's being a little complicated. So just look out for a window work message as far as if we might have some training up at the computer lab for the next meeting.
Or how many people here have a laptop that could work? Tablet?
I mean, it just
Yeah.
depends on, yeah. We'll
At
see,
this state, everybody's gonna have to
yeah.
have
Exactly, I know, and I was trying to get the IT guy to see if we could just set up a generic login for the training, but he doesn't seem to understand that we're not Theta Care employees, and I've been trying to work with them, but we'll see if that actually happens. I'm just letting you know that that might be a possibility, but we'll keep you up to date on if that's gonna happen or not. Otherwise, I don't
I think that's,
have anything.
no. Anything from the floor at all?
Oh, boy.
I have 2. Serious or funny? Which one do you want first?
Serious.
Any news on countywide?
No. I believe they're finishing up the study they're doing now. I think that's supposed to be done by the end of the year.
Okay.
So, last time I heard, it looked like they're looking at January for a start.
They're
That's
presenting to Dodge County on January 21st. When I saw Dan at the last meeting, he said he'll be starting here February 1st.
Okay. Starting as in just totally starting, just
Right.
starting?
Yes.
Got it. Okay. Funny? Could you please not bring your urine sample to the table next time? It's really kind of gross.
And if you do, bring enough for everybody.
Yeah, exactly.
I'll make sure to fill it up.
Share, okay? And the other thing I wanna tell you is you really need to hydrate more accessible. Okay.
I think that's it. So, helicopter couldn't make it tonight because safety reasons and stuff like that. I told him to just come in hot, nose it. But since they couldn't make it, Jason offered his services. He's gonna do some expert training on some topics. So, expert topics. So without further ado, Jason.
Put Jason and expert in the same sentence.
I did. He's an expert compared to me.
I thought that was like the serious and the funny. Trying to figure out where I could stand with my laptop that I wouldn't be in the way. So here's the place. This Drew wasn't playing with my computer and put anything naughty on the screen, it'll be fine.
You know, it's been known to happen.
Capture my attention.
Yep, all yours back there.
He was half asleep 4 seconds ago.
And then you heard naughty.
What? But I did.
Where did you find it?
Dang it.
tell all of them something, and we have to wrap them in it.
Alright, so we're gonna talk about sepsis. Who does not know what sepsis is? Who knows what sepsis is? What's sepsis? What's that?
You raised your hand. Colon infection.
So it's a systemic infection that you get in the blood, so the Center for Disease Control says sepsis is the 11th leading cause of death in the United States. So what's important about this is that we're really looking to catch this early. So we get these infections that are festering, like there's potential urinary tract infection or whatever else, you know. So there's really got to be looking at what it's doing. So it's a systematic inflammatory response system, and that's the first step to go into sepsis. So you can have trauma, severe burns, pancreatitis, ischemia, and infection. So that can be from a cut, that can be from, again, urinary tract infections, pneumonia. So some signs and symptoms of it that we look at the SARS, the beginning of it, is that 2 or more, so your white blood cell count is going, greater than 12,000 or less than 4,000. Things that we're gonna see in the field is your respiratory rates, greater than 20 breaths a minute, and then your heart rate greater than 90 beats a minute, with a temperature of greater than 100.4. Wait till you get out of this Celsius thing, or when they're low too, 96.8. So these are things that you can see in the field and look at your patients and kind of give the ERs a little heads up on that. So sepsis is actually the big daddy after the SIRS, and it can be bacterial, viral, fungal, or protozoa. Who knows what a protozoa is?
I don't know, I was just gonna ask you.
I gotta look it up. It's a bug of some sort. Right, Drew? So again, we're gonna go down to common causes. You got your pneumonia, UTIs, abdominal surgeries. So these are the ones that, that they open them up and maybe wound care isn't working for them. They're not getting all that pus out of there. Cellulitis, so a simple, cut to the leg and getting cellulitis. IV drug users is a big one. And then even ear infections. I personally haven't seen a whole lot of sepsis from ear infections, but I guess it could happen. So, like anything that has high-risk factors, our diabetics, our cancer patients, the HIVs, systemic steroids. When you're using steroids a lot and decreasing and diminishing their immune system. Anti-rejection medications for our transplant patients. And then powerful anti-inflammatory medications, your souped up ibuprofens and other things. So other high risk extremes of age. Excuse me. So our elderly, you got multiple comorbidities where you have infections, you have pneumonia, you have COPD, CHF, other things that are gonna decrease your ability to fight off infection. And then the biggest factor is all these people that are admitted to the hospital, so they're getting these musculoskeletal infections or hospital-acquired infections. So they go into the hospital and they're getting sicker because there's sick people in the hospital. So this inflammation will result in organ damage. So the blood clotting during sepsis reduces blood flow to the limbs, so you're not getting that blood going around. So it's kind of like a circulatory problem with people that are diabetics, etc. They're not getting that blood to flow around and get the oxygen to the tissues. So when the organs start failing, that's when you start getting into the pressure drop in the blood pressures, and that's septic shock. Again, this can quickly lead to failure of several organs, your lungs, kidneys, and liver, and it's going to cause death on that. Bacterial infections are the most common cause of sepsis. So that is why we try and start these antibiotics fast in these people. So they'll come into the ER, we're going to get our blood cultures, going to get a urine culture, try and find that source, get our blood work, and then start antibiotics right away. And some people say, well, why, we're trying to get away from giving antibiotics to patients when they don't need them. but we've already identified these that they are, you know, that they're high risk for this, and they need the antibiotics. So symptoms, you know, can start in different parts of the body, so people are gonna start with different symptoms. You might come to a difficulty breathing, so you're gonna have that rapid breathing and change in mental status. So you're thinking, oh, it must be something respiratory. Alertness and confusion will happen, and that could be like one of your first subtle signs. When they get a little more advanced, you're getting a fever and the shaking, chills, and it can not necessarily be a fever, but it can be a very low temperature also. Not urinating a lot, your pulse is increasing and rapid breathing, nausea and vomiting and diarrhea. So how can we help in EMS? So again, early recognition and treatment are best keys to the patient outcomes. So that is us looking at the patient saying, something's not right with this patient. We're gonna get our IVs, we're gonna, you know, get ready to start giving some fluids if we need to, and doing a good thorough assessment. We don't do lactates in the field, but that's one of the blood work that's gonna look at when you get to the ER. So again, by notifying the hospital staff, much like we do for stroke and stenting, when you say, I have a sepsis alert patient, that's gonna get the ER notified. Oh, okay, yeah, we need to get the ice for the lactic acid, we need to get our blood work ready. We need to maybe get some stuff to collect the urine. And again, that main goal of the assessment is to identify that septic patient to facilitate transition to the goal of direct therapy at the hospital. Again, we'll go back, you know, getting that good history, finding out did they have any infections? How long have they been sick? Have they ever had sepsis before? You're gonna find people now that you're picking up, and has anybody had this already where they said, just in the hospital 6 months ago with sepsis? When you start seeing that more, it's gonna be like allergies almost. Looking for the infection, so if you find that big festering thing on the leg, or they've got that hacking, productive cough, trying to kind of put in your mind, where can this infection be coming from? And again, you know, using as much clean technique as you can, because these patients are already compromised, so making sure that you're cleaning the IV site extremely well, not that you're not doing it already, but utilizing a mask. If you have a cough, like you come in, I'm just coughing because I have this food yet, but you know, having that mask on for yourself and doing hand washing to protect yourself. So it can transition into MODS, the multiple organ dysfunction system, and that's gonna start really getting serious on your patients, where that septic patient is gonna be imminent death pretty soon, within a day or so, or even hours. So the Robson's screening tool consists of 2 parts to help identify and isolate those patients with that septic shock. And this is so the pre-hospital management can be initiated. So it's just a tool, and what they're looking for is any of the 2 conditions that are met. So the temperature greater than 100.9 or less than 96.8. Heart rate of greater than 90 beats per minute, and respiratory rate greater than 20 beats per minute. So if you have a patient on a beta blocker that's controlling that heart rate, probably not gonna see that heart rate of greater than 90, but if you have your other 2, your temperature or your respiratory rate, be cognizant of that. Altered mental status, again, looking at what their mentation is. And then their serum glucose of less than 120. I haven't seen much correlation with the glucose, but that's, you know, a later sign. So the Swedish scale, the BAS 90-30-90, is another objective approach. There won't be a test of this, so don't worry. So systolic blood pressure less than 90, respiratory rate greater than 30, and oxygen saturation less than 90. So again, you can use these scales. Do you have the sepsis protocol? I don't know if you do or not. So that might be something that we look at down the road of, you know, getting one, or at least some more education on it. But again, just having that recognition, and once you start seeing these patients, you're saying, oh yeah, I've seen this before, and you're probably even thinking of patients you've had in the past that you didn't know that were septic. Maybe later you found out that, yep, they were admitted for sepsis. So again, the current research is suggesting that the Robeson screening tool is more likely to identify a septic patient in the field. But there's a ton of other protocols done throughout the country that talks about perfusion status and potential for infection. The Central Ohio Trauma Systems white paper includes evaluation for EMS providers. So providers in the system utilize a sepsis alert protocol referred to as code sepsis in some parts of the country. So their goal was to decrease the door to early goal directed therapy. Again, letting your receiving facility know I've got a septic patient. The criteria to activate that alert is a suspected infection and systolic blood pressure less than 90, and or 2 or more of the following criteria again: heartbeat, temperature, respiratory rate, mental status, and then lactate level when you get into a facility that can check that. So the volume status and resuscitation, so the goal is fluid resuscitation, get enough fluid in the vascular to increase the blood pressure enough to perfuse the vital organs. So when they're hypotensive, they're really not perfusing their organs. So that's why we want at least two IVs on these patients. If you can, you almost treat them like a trauma patient. Again, with that balance of making sure that, you know, you have the elderly folks that you're not overflowing them with fluid and making sure you listen to lung sounds on that. But it's important to remember that unlike hypovolemic shock, septic shock doesn't need more oxygen carrying fluid. So you're not really losing blood any place, that you're depleting your oxygen carrying blood. So the isotonic fluids are adequate, especially in the initial phases of treatment. The pre-hospital setting, we're limited to the available tools for evaluating the effectiveness of fluid resuscitation. So generally you start with a 500 bolus until you have that systolic blood pressure greater than 90. But otherwise the paramedics should really focus on the mean arterial pressure. And on your monitors, does everybody know the mean arterial pressure? So it's monitoring that for you. But if you really want to be eager, you can look at the formula and figure that out, but usually the machine does pretty good. DP is the diastolic pressure and PP is the pulse pressure. And again, most automatic blood pressure cuffs will measure that for you.
Everybody know where that is on our monitor? In the same box as the blood pressure, there's a little like number in quotation marks. That's the math.
So that's good to document too, make sure that you're documenting that, especially if you're in the range of you're doing a transfer maybe from Berlin to the Valley, watching that so you can gauge on your fluid resuscitation. So really they're looking at, it has to be at least a minimum of 60. The normal range is 70 to 110, but 60 when you're starting to get into 60, you might want to start some fluid. So if fluid's not working, then you need to go to your pharmacological support, your dopamine. So you're using whatever vasopressor you guys are carrying.
We carry dopamine, and I think when we update the protocol, it's also going to be Epigrip. As a backup.
So again, you're going to try and maintain that systolic blood pressure of 90. So you might need higher doses. So again, with any vasopressor, you start low and work your way up. So here's just a sample protocol. So again, they might meet the serious criteria, but they necessarily won't be septic. So again, the cold, clammy skin, capillary reflow greater than 3 seconds, mottled appearance of the skin. Most of us have seen that in a patient where you walk in and it's like, well, that's not good. And the blood pressure of less than 90. So what I will caution is that you have the automatic blood pressure cuffs, but if you're getting a really low blood pressure reading or you're getting really high blood pressure reading, you should probably follow it up with a manual blood pressure. Now, if you've got on seating, your responders have already gotten a manual blood pressure, so you have that one manual blood pressure, and you can kind of correlate to match with your machine, but always we don't treat the monitors, right? And if you are looking at a monitor that has an abnormal reading, make sure that you're documenting what else is going on. Is it just the monitor being kind of wampus, or is it really the patient that's cramping? Again, getting the temperature, again, the temperatures are kind of hard in the back of the rig. They're not keeping their mouth closed, you're not really rolling them over to a rectal temperature, but if you need to, you need to. And then counting a good respiratory rate. Then doing that routine medical care, assume a position of comfort for that patient, usually laying down, maybe 30 degrees. High flow oxygen as indicated and as allowed. And if they're not breathing adequately, we go back to simple BLS, you're gonna bag valve these patients. If they lose their gag reflex, remember your OPAs and NPAs, and always check a blood glucose. And that's with any of your patients that are at decreased responsiveness. And assessing the lung sounds and making sure that they're ventilating and they're oxygenating. Get that IV fluids going. Document what you think the infection is. Again, after every 500, you're going to check your lung sounds. Anything different in here? Nope, it's the same thing. And then when you're calling the facility report and sepsis alert, again, give them that full patient report. So at the hospital, there's a, hard to see on there, but we have a sheet that we fill out. This is about one of the things we do paper-wise yet, that we have our sepsis bundle that we go through and make sure that we're timing everything down the line. So again, that's where a good half sheet or a good patient report is good from EMS. That gives us our start times on fluid resuscitation and other vitals.
That would be perfect for this report, right?
Perfect for a missed report, absolutely. So again, some badge backers that we've talked about, and I haven't seen any yet. There's probably 3 or 4 leadership changes since we started discussing these badge backers. But looking at putting these on there so you have something in the ambulance to look at. And maybe that's something that you even make some, just put them up there. So again, what your next steps is that you guys develop protocols out here and look at it, work with your leadership team, your medical director, and see what protocol will work for your service. Again, this is nothing really earth-shattering that the medical director should really scoff at. And then just more education on sepsis. And this is just a touch on sepsis. I'm not the expert, as Damien says I am, but I did sleep at a Holiday Inn a couple nights ago. Any questions on that?
Would ETCO2 be helpful?
Yeah, I mean, that's gonna show your ventilation. I don't know what numbers you'd see on that. Drew, do you have any research on that at all?
Yeah.
Would it be acidotic or?
It would show acidotic. There was a good study done by UW 2014 that showed a correlation of fever, hypotensive with high end tidal with sepsis.
Okay.
And that's actually part of the protocol at UW now.
Cool. Yeah, that's be something to look at.
That's something that, we have on our monitors that, I don't know, I try to use it as much as I can, but if the patient's breathing 30 times a minute and they're still acidotic on the ETCO2, that's telling you something's going on, internally.
And that is something that we're just even, and finding that in the hospital, we really haven't even grasped waveform capnography like a lot of the other partners in the country have in the field. So I'm really hoping the hospitals are going to start buying into it more. And then again, if you have it on your monitors, go ahead and change it. So. All right. So I would like to take just a couple minutes yet and talk about, well, we'll get into our tech stuff. But what are some issues you guys are seeing in the field? How about C-spine? C-spine, selective spine mobilization. Have you guys been having any problems with that coming into the facilities? Have been giving you grief at all? Or?
There's always the, why didn't you,
Well,
so
the,
Why did you? Yeah, that's a good one. Why did you?
so it's kind of one of them balances that we look at. It's like, okay, so you did put a collar on a patient. Why didn't you put a collar on a patient? So you're documenting that they or not intoxicated, they didn't have a distracting injury. So the gray area gets the distracting injuries. What's a distracting injury? If I got a hangnail because I'm a guy, it's gonna hurt like heck, you know, and that's a distracting injury that I may have a cervical spine injury. But if you have somebody that has a pelvis injury or arm fracture, that would be more so to your mindset that that's a distracting injury, correct? There's actually we'll talk about it at our tech on Wednesday night, that we're looking at the greater than 65-year-olds that have fallen from standing height, that we're finding that they're having cervical injuries. So now they're talking to you, the normal mentation, it's almost that where you gotta have that feeling that it's like, you know, they fell 10 feet or so, it's not quite that 12-foot mark, but maybe we need to start looking at C-collar in these patients. And we were gonna do a little hands-on tonight, but we'll save it for another night, is proper placement of a C-collar, because we're getting a number of patients coming in that C-collar is on, or their head's twisted way up like that, or the collar's coming around the back, or they're chewing on the bit, you know, from flipping that up on the chin. So just something to kind of look at on your patients, and make sure that you're documenting. Other things that I've been noticing is not documenting that CMS after placement. Always make sure that you're going through that. And before placement, the story that I got is years ago, I went out to a rollover, patient was ejected. I knew the patient, got him on the longboard, got him into the rig, did my assessment on him, and he didn't have any movement from the waist down. Immediately I felt my heart rate go up. I probably was septic at the time. Heart rate went up, respirations went up, kind of a little bit of a pale, and I said to him, Emery, when couldn't you feel your feet and when couldn't you move? He said, immediately when I woke up in the ditch. So this was something that's always stuck with me, that we went through all this, and I skipped that one component of checking at CMS and lower extremities, and it just kind of stuck with me on that. So now I'm kind of stuck in my head that I check them all the time like we should. But anyway, I'm sure that's not an issue with most of them. Let's see, another case. So you got a patient that's being transferred to another hospital. We'll say Michigan, just to keep it out of it, right? So we know where the patients are going. So you're having an issue with the pulse ox on the patient, and they were on BiPAP, now they're on CPAP, and their saturations are reading low 60s, and it's just not jiving, because the patient's alert, oriented, talking to you. So you get to the hospital and they jack you up because, hey, you brought me a patient that's in the 60s, for SpO2. That's where good documentation comes in place, because when you read the report and you see, okay, we don't think this was accurate because the patient wasn't presenting with cyanosis, he was alert, oriented. I think it was equipment function, because we always talk about not treating the monitor, right? You're treating the patient. So if you have, and the vice versa, you have a patient that's having difficulty breathing, has an SpO2 of 100%, you're gonna treat the patient with oxygen, correct? You want to treat that breathing. So on the same side of the sense, so good narration will help you on that. And then when the rest of the story comes out, when you read the report, then it's like, oh, okay, I get it. But make sure that you're giving that information in your NIST report, or when you're giving your handoff report also. It's just gonna make life a lot easier for you. Other questions? Make sure there's no questions. Don't have anything else to say.
So I guess I've always struggled with, if you have a patient that has chronic back pain, say, and they get into an accident, and now they're going, my neck hurts a little bit. Our protocols haven't been updated in a couple of years. Our protocols read, if you put on a collar, you're mobilizing them completely. What are other services doing in that situation where it's not a significant trauma, it's not crashing at 60, it's more or less, I was on my porch, I fell down 2 steps on the stairs, and now it hurts, in this general area. Are they just putting on a collar? What's
collar, scoop, take the board off, and you get them on the stretcher. That's what a lot of the services around the area want to for a protocol. Spinal boards are good for moving the patient from the ditch to the stretcher. They're good for that patient that's unresponsive. They're good for CPR, that's that hard thing underneath them. But really, the studies are just showing that that the boards are doing a lot of damage and a lot of pain, especially with your transports. I mean, if you have to ground pound it from here to the trauma center, any place, I mean, that's what, 20 minutes, 30 minutes?
From here, 35.
Exactly. So now you're getting that breakdown, you're getting that, and that board really isn't doing anything for holding that spine still. You know, again, if they're awake and alert, and this is where the debate gets in even about C-collars, you know, that most patients are able to splint and hold their neck in place.
Right.
It's the patients that are unresponsive, that have no control over that head, or that body movement, so.
That's what I was gonna ask, cause when I went to WEMSA, it was quite a few years ago now, they were talking about mobilization, you know, that patients are naturally not gonna turn their head if there's pain. And that's why we were talking about the collars, and that I thought it was slowly going away, that the collars have been shown to do more damage. Granted, it's because we do use them improperly, but still, it's still a three-size-fits-all type of thing, and that is not a we are not three-size people.
Right.
So I was amazed that we still are really pushing the collars, because WEMSA was really trying to, I mean, there's other states that the collars are gone. It's the blocks, it's the self.
So I don't think we're ever gonna see the collars go away, and this is coming from the neurosurgeons that are really pushing this. And we get these people that come in that have these cervical fractures, and their treatment is, when they left, we had one the other day at a C2 fracture. Treatment for him was they put him in an Aspen collar and sent him home. So obviously the C collar and the Aspen collar are two different things. So if anybody's ever had a collar on for any kind of time, and then you switch to the Aspen collar, night and day difference. And maybe next time I can bring one of them in to show you. And that's what I really, wasn't for the damn cost of them. I think that's really what EMS should go to. You know, but them suckers are like $60 a piece. So now you're putting a collar on every person that's fallen, you know, and it adds up. But what's right for the patient is what we have to look at. But the backboards for sure, like I said, I don't see much use for them. And that's just Jason talking. That's not any authority at all in medical control. But the collars still have a place. But again, it's utilized them correctly. And if you've got a guy like me that's got a chin and a chest and nothing in between, the collar's not going to work out well. So this is where you're taking your other things where you're using that towel roll. Remember your horse collar and your collar roll, and you put your blocks on and you strap them down good, and that's gonna hold. And just make sure that you're documenting why, and don't try and force something that doesn't fit. Don't put a.
That's the key, because it gets beat into our head, and that's what the instructor down at WEMSA was really preaching, is that it gets beat into our head that you have to put that collar on, and it doesn't matter if it don't fit. You've been told that it's gonna fit, and you're gonna make it work. We now have 5 settings, so it's gotta fit, and that's the thing, is that I think we have it beat into our head that it has to happen, and it's gotta be that way. You know, we are the MacGyvers in the EMS field, we can make other things work.
Yeah, but I brought somebody with a horse collar and the doctor ripped it off, as, what is this?
Exactly, and
So-
that's what needs to be brought up, is that.
But that's like your longboards too, the ER. You guys are telling us, no, the longboards aren't necessary, but then you take them in without it on, and the ER doctors and the nurses are
Depends on
bitching
who's
at us
there.
because we don't have the longboard underneath. So-
that's education, it has to come back and
Right.
talk
Right.
about, because
So-
we have doctors that are old school yet.
Yeah.
We have the neurosurgeons that, why aren't they on a board? What do you mean, why aren't they on a board? What do they need a board for, you know? So again, this is that conversation that needs to evolve, and that's where Paul will help. So if you work with Dr. Paul and get good protocols, then the only thing you gotta do is, let me respectfully say to the doctor,
Right.
let's discuss this when we can. Here's our protocol, this is what we're told to do, speak to my medical director, you know. Having that knowledge and the science, because again, people are gonna complain, one way or the other. You didn't have a collar on, you did have a collar on. Now you had a collar on, now I gotta take some x-rays, I gotta clear this because a collar shows that you think there's a spinal injury, and now we have to prove that there's not. The only way to do that is to light them up with energy, so, radiation, excuse me, no energy.
It's good to remember that, we still have to operate under our protocols, even though, Jason's telling us. Our protocols, I refreshed on them today. We do selective spinal, but if we get to the point where you want to put a collar on, our protocols say it's all or nothing. So if you're putting a collar on, you're on board. I don't think Dr. Pro is under that mindset anymore, the last time I talked to him, but that's still what we have on paper. So we have been working with him to update the protocols. It's just a slow process. We review it, we send it to him, he reviews it, sends it back to us.
So even somebody who's up and walking, you want us to put them on that?
If you can clear them using the 5 or 6 criteria,
It's just
if you can clear them, you don't have to do anything. But if you have a reason to put a collar on, our protocols still say they need to go on board. Now, you could always call medical control, get it ordered and not do it. That's always an option. But I don't think you're going to get in trouble for it. But if it ever goes to court and they go, hey, you deviated from your protocol, why did you do that? It's just covering your butt. It's not saying I agree with it, it's just saying legally we have to follow the protocol or document why you did it.
It kind of goes back to years ago with, you had a patient that was involved in a 70-mile-an-hour rollover. I mean, these were trauma wounds. You need to fly these patients, now we're going out to these scenes and these guys are getting out and brushing themselves off, and what's going on? Our vehicles have changed. So, but again, that mindset of years ago is still there, and that's what the best practice is, and sometimes the best practice hasn't caught up with that. And again, that's the discussion I have with the medical director. Same thing, I've always said, if something should change, it needs to come from the people that are doing it, to bring forth the studies, and then have that conversation with the doctor, because I don't know how much the medical directors have time to read through everything, that they're gonna go with what's worked, they're gonna go with what the protocols are for the hospital. Some of our docs are gonna go by because every time they do something just a little off, back their neurosurgeon's gonna come and jump down their throat. It's just that. So again, just looking at it, and so again, yeah, you get these 10-foot falls, and some of these people are bouncing fine, that they're not having any problems. But again, do a good assessment on them, making sure that you're touching everything. And if they have some pain or injury, you cannot rule out that they have a cervical spine injury. And that's what it really boils down to. And is it going to be 100% correct all the time? You can have that patient that's walking around that, they're walking around with a pelvic fracture, and how are they doing that? You're going to be a man with a pain mill. But anyway, so. But yeah, so that's all. That's Jason speaking. Again, follow your protocols and, do professional development. Read these studies. Look up things on the movement for C-collars and mobilization and sepsis and, stroke techniques and, other things that we should be looking at. So, if you'll entertain me just for a little bit, I'd like to talk a little bit about one of the other hats that I got, and Heather knows a little bit about. It's our pediatric emergency care coordinator. Has anybody heard this one yet? So through Children's Alliance, we're looking at establishing a pediatric emergency care coordinator in each ambulance service, and that person's really just a champion that's going to kind of oversee pediatric care, looking at charts. And getting all this information for education that's coming up. Yeah, please go ahead.
Back to the C-collar and the board. Even in today's curriculum updates that have been coming through, C-collars are even taught as they're just there to remind the patient not to move their head. Cause no, it doesn't do anything other than make it uncomfortable so they don't make their head. It does not hold his neck in place at all. And the textbooks have also changed, and the curriculum has also changed that backwards are movement devices. And securement of unconscious only. So that's the way we are starting to teach. Protocols need to be updated to follow that, but that's the way the education is going now. Sorry for the delayed response, my mind is very slow today. You should.
So we'll talk about the pediatric emergency care coordinator. So the nationwide, they're looking at pediatric care in EMS and what we can do to support. I'll work on that for a second. So really, it's how do we get this education out to the services? How do we find funding for the equipment that you can't get through your associations or other things?
I'm gonna try to break it.
So EMS for Children is through the Children's Health Alliance in Milwaukee. They have the Asthma Coalition that's in that, the Infant Death Center, Keeping Kids Alive, Wisconsin Medical Home, Oral Health, and then Reach Out and Read programs. So the EMS for Children is the driver of this one. So what we started looking at is the history of where we started and where we're going from here. So in 2000, we'll just talk.
That's all I got.
Yeah, we'll just talk. So in 2007, the Institute of Medicine released Emergency Care for Children Growing Pains, specifically recommended that the EMS agencies designated pediatric emergency care coordinator or champion to ensure that training guidelines are available to field providers to maintain competence in emergency care of children. So we put a core team together last year of a bunch of ambulance services from around the state and talked about how we could get a program together. And we did this with nine other states, Kentucky, Connecticut, Montana, New Mexico, New York, Ohio, Pennsylvania, Rhode Island, and it was us that were in this learning collaborative. So we made a definition for the pre-hospital PEC. It's an individual who is responsible for coordinating pediatric-specific activities. A designated individual who coordinates pediatric emergency care need not be dedicated solely to this role. It can be an individual already in place who assumes this role as part of their existing duties, because we can't just have one person that does just one thing in EMS, right? So the individual may be a member of your agency or work at a county or regional level and serve more than one agency. So the responsibilities are that we're looking at the pediatric perspective that's included in EMS protocols, ensures that fellow EMS providers follow pediatric clinical practice guidelines, promotes pediatric continuing education opportunities, oversees the pediatric process improvement, and ensures the availability of pediatric medications, equipment, and supplies. So it's kind of that person that looking at your ambulance saying, when's the last time we took your Brazil bag out? Have we trained on any of these equipment? So again, it's promoting that agency participation in pediatric prevention programs, promotes agency participation in pediatric research efforts, and it liaises with the Emergency Department Pediatric Emergency Care Coordinator, which is still working on that. So, and it promotes that family-centered care at the agency. So not only taking care of your pediatric patient, but the family that you're picking them up. So, some of the benefits I have in the PEC is identifying the gaps and ensuring the resources that you have for your service. Maintaining that relationship with state EMS for children infrastructure. Working with the state and the local authorities for relation coalitions. Establishing and maintaining offline and online pediatric emergency protocols. Establishing quality improvement plans with pediatric specific indicators. Coordinating with dispatch to provide evidence-based pre-arrival instructions for children and or caretakers, and reviewing on a regular basis the medications and devices available for pre-hospital care of children. So this is a really neat map, we can show you some other time. So when we started this, we had 21.1% in the state that had a PEC. So it's kind of a slow start. We had 8 or so that were firmly committed and 16 waiting to get approval to get somebody in place for that. So right now, currently, we're at 102 services. 86 were last March, and now I'm up to 102 now. We've got educational opportunities that are evolving. There's gonna be an online respiratory module that's coming out hopefully next week. It's been kind of a long process that you're gonna be able to go online, get this education, and it's gonna work towards your licensure. You'll be able to use that for your licensure. And then we're gonna recognize and support the starting at the ground level for the PEC services. So we want that strong collaboration. We want the PEC to be there for you. So EMSC will be looking for grants to, the fund equipment, provide education free of cost. Free to you, the providers. And then having a lot of resources in a virtual toolbox online, because we realize that time is it's hard to get time to do everything. So it's hard to travel, it's hard to go to all these meetings. So if you have some downtime and you can do it electronically, that works well too. So we've got a website that's on chawisconsin.org, and if you just search EMS for Children Wisconsin, you'll be able to see that. And it's got a virtual toolbox on it. We're gonna do meetings quarterly virtual, and then in March we're gonna have a meeting in Stevens Point. The 18th in the afternoon will be pediatric safe transport of kids, and then the next day will be all day pediatric seminars. It's gonna be free of charge, and then we're also gonna look at regional educational offerings, and we've done a few of them already with our team. So that is what PEC is. So Heather is still in your PEC here, right? So she'll be getting emails, be able to disseminate that out to the group. And again, just get online and look at the website and utilize the resources out of that. So any questions on that, or I think I've probably taken enough of your time tonight. All right, thanks for putting up with me.
Thank you.
Thank you.
That's all we have tonight. You're welcome to take some food if you can find a to-go container. Wow, I can't talk. Please take some food.
Tape it like the,
I've done my to-go containers.
We can use a big 55-gallon drum anywhere. Shock it till you know it.
Every single time we say travel. That's a good choice.
Yeah, you can.
Hello, Mr. Tomorrow night's meeting, or training, doesn't have to be about.
Just one up.
I couldn't do it from the window. For some reason the glare stops it.
And he qualifies because he's on the fire.
I'll email
And yes,
Peterman.
it's one more training.
Whatever it is, I'm gonna throw it out. It's on their final exam.
But Ernie wanted to talk to,
Yeah.
Travis, but, he didn't,
I don't know how to do it.
Okay, we'll see you later, Peter.
I don't know how to turn that.
So, I can't believe you didn't, is that off now?
Oh, no. Can I just turn it off? Do I have to save the video?
I think you just turn it off.